I'm Professor Jamie Cooper and I'm an intensive care physician here at the Alfred Hospital in Melbourne, and I'm going to talk to you in the next few minutes about a really important research trial that we've recently completed and has just been published last week in the New England Journal of Medicine. It's called the DECRA trial, and it's important in a number of different ways. It's firstly important because it involves hospitals across Australia and New Zealand and also a hospital in Saudi Arabia. There were 16 sites in total. It's also important because it was funded by the National Health and Medical Research Council of Australia, the NHMRC, together with the Intensive Care Foundation and the Transport Accident Commission of Victoria. All these funders and a couple of others put their efforts together to get this project completed, and to complete it in a way that was a very high quality, sufficient to be published in that journal. Now, the reason that we did this trial is because we have a lot of patients with severe head injury, and we know that their outcomes after severe head injury are a lot less optimal than we would like. In fact, if it's a severe one, only about 50% of those patients with our best management in Australia end up being able to live independently in the long run. And so that's a terrible statistic that we'd like to improve. Another statistic is that in Australia every year there's 1,000 such patients. Most of them are young, and most of them are young men, like the man I have behind me at the moment. So it's a tragedy. It's extremely large human tragedy for families and patients, of course, but also it's extremely expensive to the community and costs Australia about $5 billion a year. Now, what we aim to do in this study is to test one of the therapies that's used to improve outcomes in severe head injury patients, to find out whether it was truly an effective therapy. And there are many things that we do in ICUs, intensive care units like this, to give patients their best chance, and many of them are directed at controlling pressure in the brain. We measure the pressure through little catheters, we control the airway and the ventilator, the resuscitation fluids that they get, their salt balance. We use things called osmotherapy, and we use, I may have said, sedation. So there's a lot of different ways that we work to an anaesthetic drugs to control the pressures and and often that involves a coma, kind of deep anaesthesia therapy for a number of days. But in about 10% of patients, those more routine techniques are not sufficient to control the pressures, and that's when we're in a territory where we're not exactly sure what to do. And one of the things that can be done at that stage is to do a surgical operation called decompressive craniectomy, and that's what this talk is about, and that's what the study is about. Because decompressive craniectomy is pretty simply, it's surgeons, neurosurgeons in an operating theatre removing a piece of the patient's bone to enable the pressure, the skull bone of course, to enable the pressure in the brain to go down to a safe level. And it needs to be a large piece of bone, and so it's usually the front of the forehead area. The surgeons know how to do it in a safe way and in a way that doesn't leave scarring, because the incisions are high up, high behind the hairline. It's not a new operation, it's been around for many years. It's used in different parts of neurosurgery quite successfully. And importantly, the bone is put back at a later time when all the pressures settle down and all the infection has resolved. So the thing that we didn't know was whether craniectomy, which is what this operation is called, was effective to improve patients' outcomes in the long term. Because there's other things that we can do instead. We can use even heavier doses of anaesthetic drugs, particularly drugs called barbiturates. So we set this up as what's called a randomized controlled trial, which is the highest quality trial to test this this procedure. And so so there were 155 patients enrolled in the 16 sites, Australia, New Zealand, and Saudi, over a period of about 7 years. So it took a long time. It was a difficult study to do, and of course it was quite complex because many other things were going on in the patients at the same time. But we consented the patients, we worked through the ethics committees of each of the hospitals, and we, after enrolling patients in the trial, we what's called randomized them to either receive the best current therapy that's available without the operation, or to receive all those best therapies and the craniectomy operation. And then we followed those patients through their hospital stay, and then more particularly we measured their long-term brain functional outcomes or neurological functional outcomes at, I'll just turn this thing off, but we'll just keep going, at 6 months after their accident time. And that's extremely important because outcomes from head injury patients do continue to improve over time. They start to plateau at about 6 months, but they even improve beyond that. And so this was a careful, long-term analysis, and we found some really quite important things. Firstly, we had 155 patients split into the two groups. Secondly, the study was well designed and the groups were very well matched for the most important predictive factors for outcome in head injury patients, and there's quite a few of those, but key ones are their age and their ability to function or their coma score at the time they come into hospital. So those things were very well matched. And then as they moved through the hospital scene, we measured important things like their brain pressures, their stay in the ICU and their stay in hospital. And all of those things improved dramatically. The brain pressures were markedly reduced by the surgery compared to our best other therapies. The time on the mechanical ventilator, you can see this patient's on a ventilator, and the time in the intensive care were both reduced significantly and substantially by 4 and 5 days. And so the clinicians tended to see that things seemed to be going well, and it became difficult for us to enrol patients because particularly the neurosurgeons were convinced, or some were, that the surgery was particularly being of benefit for patients. And that is what many previous less high quality studies had suggested. Series of patients had certainly suggested that this surgery improved outcomes and reduced brain pressures. But the most important thing that we discovered was, despite all of those things, at the 6-month time point when we carefully measured their functional outcomes in a blinded way with a special telephone questionnaire system, we discovered that the outcomes of the patients who had had the surgery were significantly less good than the ones who had had the best medical therapy with the barbiturate coma. And this was a striking new finding that in some ways didn't make sense for a while until we thought about it some more. But it was an extremely important finding because it tells us that we can maximise the chances of a patient's best outcome by using our standard intensive care therapies, by using neurosurgical intervention with catheters in the brain to let down pressure, and also using heavy barbiturate anaesthesia in this group of patients, in patients with diffuse brain injuries. We didn't include patients who had blood clots or hematomas because they're different and they're better managed neurosurgically. But in this group, we found that we could improve outcomes by 20% by doing that rather than doing the craniectomy. Now, this finding was completely different to what other series had suggested, was completely new, and I think that's one of the reasons why New England Journal of Medicine chose to publish it, such a high-profile journal. It is going to change practice in the way we handle and manage patients in the ICU after severe head injuries when they've got intracranial pressure problems. I'm quite certain that many surgeons, probably most surgeons, will change their approach in this situation. The surgery had been becoming very popular, not only in Australia but also in the US and Europe in this particular situation, and I'm sure that will now change, and heavy anaesthesia with barbiturate coma will become very clearly, I think, the way to go. There are other studies that need to be done. There's a study in Europe and UK that's ongoing at the moment testing similar findings, and we'll wait for that. But it's already completely clear that we can maximise the outcomes in these patients, as I said, by 20% by adopting the drug coma rather than the surgery. So the surgery was a really good idea. It had terrific short-term outcomes, but it did not have good long-term outcomes for patients. And if you want to translate these findings into cost savings, we're going to do careful cost-benefit analyses over the next year, but we already know from costings that were done last year by Access Economics for head injury patients that we could save, the Australian community could save more than $100 million a year in long-term rehabilitation costs by directing just this small specific group of head injury patients towards heavy anaesthesia and barbiturate coma compared to doing early decompressive craniectomy. So that's the main message, and thank you very much.